So hello and welcome to the second video presentation called Managing Suicide Risk via Video Consultation. My name's Dr. Lizzie Croton. I'm a GP in the Midlands in Birmingham. For the past couple of weeks during the COVID pandemic, we have moved all our consultations online. So we are consulting remotely via video and also telephone, as I'm sure many other people are throughout the country. So I wanted to go through the assessment of suicide risk. This is something that we have had to do quite a lot, sadly, over the last couple of weeks. And it's always a challenging consultation, whether you have the patient in the room with you or over the phone or on video. And these are just some tips really to make things easier, as it were, and safer for the patient. So we talked earlier about general points about video consulting, so I won't go into those here. But essentially, once you've got the patient on the video, or this is also appropriate for the phone as well, I think it's always important to ask directly about suicide risk and sensitively. We all have different ways of asking about suicide risk, and it's best to use the way that works for you. I tend to say something along the lines of, have you had any thoughts of ending your life or harming yourself? Or words to that effect. And it's important to ask in a sensitive way, so modulating the tone of your voice. I'm sure we all do this anyway, but care, empathy, and just be aware that it is a difficult question, and it's really important that the patient knows that we are concerned about them. So we'll move on to the specifics. So after we've asked the question, there may be a number of responses the patient can give. They may say, no, I've never had any thoughts like that, or I'm fine. They may say they have had those kind of thoughts, or they may give a slightly on the fence answer where they may say something like, well, not really, or which kind of implies that they might have done. So it's always important to explore this in a sensitive way, because it's very rarely a yes or no black and white answer. Suicidal thoughts are very common in the general population, and the studies suggest that asking about them directly will not increase the risk of the person actually carrying the action out. So I would want to know, if the person was expressing some suicidal thoughts, how long they'd felt that way. So is it something that they've had just a day, or is it something that pops up every so often? Is it something that tends to happen if they get stressed? How does it normally manifest itself? Does the person have a plan? Have they actually made plans? Have they gone beyond the thoughts to thinking about, well, how am I going to execute this? And if they have made a plan, how likely are they to carry this out? Have they thought about it? So there's different stages to this. And generally, the more of a plan the person had, and the more steps they'd taken to carrying it out, I think the more concerned I would be. For example, if a person was planning to, jump off a high building, if they had thought about how they were going to get there, if they'd booked train tickets to get there, that would be a lot more concerning than perhaps somebody who'd had thoughts of doing it but no plan. It may well be that the person has a history of deliberate self-harm, so they tend to harm themselves, or they tend to hurt themselves in some way to punish themselves, and this is associated with an increased risk of completed suicide. But it may be that the person doesn't want to die, it's more that they use this as a particular coping mechanism. It has at some level a positive intention for them, which may sound strange, but it may well be that it reduces stress, it may well be a defence against difficult emotions, or something else. So actually talking about the intention of this behaviour can be helpful, because it can help patients understand perhaps what they're trying to achieve by doing these behaviours, and if there's another way of getting their needs met. I'd also ask about the presence of intrusive thoughts, and thoughts of suicide, thoughts of not wanting to be here anymore, thoughts of not, not their life not being worth living, or people not wanting them around, are very common. Sometimes they come and go. Sometimes they can be very intrusive, and they're very difficult to resist, and the patient finds it very difficult to block these thoughts out, and they can't distract themselves from them. And so the more intrusive they are, the more concerned I would be. We talked about the mental state examination, and that is something that we as GPs all know how to do. We can observe the patient on the video. We can see how they are. Are they tearful? Do they appear very calm? They may appear very agitated. It's different, so it's useful to be able to see people on the video so you can get an idea of how they are. Some people can appear very calm if they've actively decided that they are going to end their life, and there's a sort of relief with it, which we do sometimes see. So if the person seems very calm, please don't be reassured by that. So important to look at protective factors as well. And protective factors are things that would stop the person carrying out their plan. It's quite common when you talk to people for them to say, well, I do have those kind of thoughts, but I would never do it because it would upset my family, it would devastate them. I couldn't do that. And that's really important. You may also find evidence when you're talking to the person that the person appears to have made plans beyond the immediate day. They might be looking forward to doing something in a few months' time when the quarantine ends. Hopefully sooner than that, who knows? But they might be looking forward to a holiday. You may get some clues that the person isn't perhaps completely committed to this act. And so it's important to find protective factors as well. And we go on to further assessment of risk. Just touching really on a little bit of what we talked about on the last slide. When would they carry this plan out? If they are going to carry it out, are they going to carry it out when they get off the video to you, or perhaps later? And that will decide on how you are likely to manage this person, what actions you're likely to take next. So specific personal risk factors, and these are things like a previous history of self-harm or suicidal ideation, previous attempts, how recent have been those previous attempts. That's always very, very important. If the person was male, if they lived alone, if there was evidence of hopelessness. Also, access to lethal means. If you know that that person is a health professional, for example, and they have access to heavy-duty drugs, or if they have access to firearms or something similar, then that's going to increase the risk. Other questions are things like, what are they looking for? With the suicidal state, it's difficult to talk the person out of it, because it is in the state, the patient kind of can be very fixed in the state, and if you try to talk them out of it, it can almost seem like it can cause a disconnect basically in the relationship, because they're invested in how they feel. So it's really important to keep the connection going, to show that you care, but to just kind of understand the state really from their perspective, rather than trying to talk them out of it, which doesn't work a lot of the time. The other thing is their social circumstances, who's around them. This ties back to the previous presentation when we talked about other people in their lives, other people who can keep an eye on them. Do they live alone, or have they got other people around them who they can lean on and talk to? So we come on to making a plan, and this is what are we actually going to do? What action are we going to take? And the way I like to think about this is, what is the safest action for the patient now? Now, obviously, we're in the middle of a pandemic, so we're going to try, if possible, not to send the patient to A&E or call the police, just simply because of the demands on the service. Also, A&E often usually isn't the best place for somebody who's feeling suicidal, for many reasons. But if you are concerned and you have the patient on the video and they are expressing a desire to end their life, and you feel that they may do that imminently, then I think you have to put that to one side and decide what is the safest thing for this patient right now. If you talk to the patient and they say, well, actually, I've thought about it, I've made some plans, but I don't think I feel better after talking to you, and they start to kind of come round, then that is a good sign as well, but clearly they need some follow-up. So it may well be that you can avoid sending them to A&E or the police, but clearly that is an option if you feel that warrants it. In Birmingham and around the country, we have crisis teams. These can be very useful, and currently in the pandemic, our crisis teams will see patients that we've assessed remotely. And usually what they do is they will call the patient later on, check in with them. They may assess them face to face. It depends. The patient may also be known to the crisis team. That's the other thing to have a look at when you review their notes before you see them. They may already have a crisis team involvement. They may have a CPN. They may have dedicated mental health workers. So we may need to refer to the crisis team. It may be after we've spoken to the patient, as I said before, that they're feeling better, that they're not going to go through with this plan, in which case, with the patient's consent, we may go with home management. That may involve using relatives and friends to check in with the patient's consent. It may also be helpful to have a designated relative or friend who number is on the notes with the patient's consent, who we can phone if needed, if we cannot get hold of the patient. This can be really useful because, again, it increases the support network around the patient, so the patient isn't completely dependent on the GP, because this is a really difficult position to be in, and it really helps improve the patient's sense of connectedness. So use of relatives and friends is really important. And the other thing to think about is the interval for follow-up, and that will depend on how risky we think the patient is likely to be. It might be that we call them later on that day. It might be that we call them in a couple of days. It might be that we talk to the crisis team and call them after the crisis team has seen them. This is something to be negotiated with the patient and their relative / friend, if appropriate. It may also be a good idea to have a plan as to what you're going to do if you can't get hold of the patient, and that's when involving a friend or relative can be really, really helpful as well. So going on to making a plan too, as always, clear documentation needs to be put in. The notes, including verbatim comments and plans. Safety netting, very, very key. The patient may be feeling better. What do they need to do if they're feeling worse? And this involves dedicated crisis support information. If they start to feel that they are suicidal again, who should they call? They could call you. It depends really on what systems you have in place. Using family members as well is useful if you feel that the family members are going to be a good support to the patient. Typical crisis support includes charities like the Samaritans, who are very much open for business at the moment. They're not doing face-to-face consulting, obviously, but they are. The phone lines are open. Papyrus is another really good service that we use. This is for younger people. The Mind website has a section on urgent support. Patient can go to A&E, rather not in the current climate, but that it certainly is an option, and they should be aware of that. Or they can call 999 as well. Moving on to medication management as well. So if we're prescribing medication, this is a really important thing to think about. Because although the current antidepressants, namely SSRIs, are less toxic in overdose than the older style tricyclics, there still is a risk. So we need to think about how we are going to, if we are going to give this patient medication, how we're going to reduce the risk. And that may well mean giving smaller amounts, delayed prescriptions, weekly prescriptions. Again, as I said in an earlier presentation, reducing footfall into pharmacies is important. So it may well be, if the patient has a trusted relative or friend, that they could hold the medication and give it to the patient. Again, it depends on what support the patient has around them. And finally, how are you going to follow this patient up? It may be useful to, if the patient has a relative or friend, to actually ask them and task them to phone you up and let you know how things have gone. If you are referring the patient to the crisis team, unfortunately at the moment sometimes the communication is not as good as we would like it to be, so there is a possibility the patient can be seen and discharged and you may not be let know about it. So it can be important to write yourself a task, or ask reception to follow this up, just to make sure that the patient doesn't fall through the net if they are seen by the crisis team, to make sure that they have follow up by yourself. It may be helpful to contact them a couple of days after discharge, or perhaps even sooner. So those are all important things to think about. So finally, some references. I want to start with saying stayingsafe.net, and this is a really, really excellent website, which one of the contributors, who's very well known in the field of suicide prevention, Dr. Alice Cole-King, who is based in Wales. This is a website that we use a lot in our practice. It essentially has a lot of information for carers, but also people who experience suicidal thoughts, and includes information on making a safety plan. Safety plans are a really, really clever idea and useful idea, and many of our patients have found them very helpful. And the idea is that they make a plan when they're feeling okay as to what they're going to do when they're not feeling okay, and steps that work for them. So that might involve calling particular people, it might involve certain actions, and the idea is that they make this plan when they're feeling well, and then they've got something to do when they're not feeling well. And many of our patients carry these around with them, or they have them on their phone. It's really good. It empowers the patient and it helps them get a sense of agency, really, and helps them experience getting out of these states, which I think is really important and imperative, really, for recovery. I've included references to Papyrus and also Mind. I haven't put the website for the Samaritans on, mainly because I forgot, but I think we can find them. All really fabulous charities who do fabulous work. And I do believe, actually, the Heads Together Foundation, which is William and Kate's charity, isn't it? They've also got lots of information on there as well, including text services, which can be useful. So there's just a quick whistle-stop tour of suicide assessment, and I hope you found it useful.